reasons why we would sedate patients. So mostly for anxiolysis, and also to remember that we are doing painful procedures often in the ICU, and that patients do experience pain. So it's as much about analgesia, which we'll speak about shortly, as it is about sedation. There's some patients where we really want to work to reduce their metabolic rate and their oxygen consumption, and that's especially in our patients with very high oxygen requirements. So as we've seen lately with this new surge of influenzas, we really have to keep those in order to ventilate and oxygenate them adequately. If we get our sedation right, we can reduce post-traumatic stress disorder. If we get it wrong, we can increase it, which we'll speak a little bit about now. And then there's some states where we really use sedation as a treatment rather than an adjunct. So patients with raised intracranial pressure, abdominal compartment syndrome or raised intra-abdominal pressures, acute alcohol withdrawal syndrome, status epilepticus, and some acute psychiatric disorders. We might use it as a treatment modality rather than as the usual facilitative role that we usually use it in the ICU. So what's very important to understand is that sedation is not the same as sleep, but actually sedation disrupts our sleep architecture quite a lot, which is what leads to a lot of problems in the ICU with sedation. So if you think about normal sleep physiology, you've got non-REM sleep and you've got REM sleep. And your non-REM sleep is divided into N1, N2, and N3. And if you see then N3, that's your slow wave sleep or your deep sleep. And that's only about 20% of your total time. But that's where we really get our psychological and immunological benefits of sleep from. And what if we don't sleep? We all know how this feels. We all go through it on a weekly basis, not sleeping. And we know that there's behavioral and psychological consequences. I always say to people, I bought my first home when I was post-call, which is just an expression of behavioral abnormalities when you are tired and post-call and not sleeping. It changes our cortisol levels, so we become, we live in a constantly stressed state if we are sleep deprived constantly. You get changes in your cytokine expression, and what's interesting, there's a lot of work on this. You actually get increases in your pro-inflammatory cytokines, so your tumor necrosis factor alpha and interleukin-6 are markedly increased in patients who are sleep deprived. It increases our cardiovascular risk over the long term, can lead to psychosis and cognitive impairment. We see that with people who have difficulty with decision making in the post-call state, those who can't drive in the post-call state. And it might lead to dissociated thought processes. So it's problematic to not sleep. So do sedatives help you sleep? Like I said, no, they don't. Propofol and the benzos promote your N1 and N2 sleep, which is not restorative sleep, and they actually inhibit your restorative sleep, your N3 and your REM. Opioids inhibit REM. Dexmedetomidine, everyone thinks that Dex gives you normal sleep architecture or mimics sleep properly, but it doesn't actually. So it also inhibits N3 and REM, but it does it to the least extent of all of the agents that we have available. So it's probably the least troublesome in terms of disrupting sleep architecture. And if we keep patients on long-term deep sedation for a long time, we'll see there's a lot of adverse events that we encounter because of it. They can have obviously prolonged coma as a result of us keeping them sedated. They get delusional memories about their ICU experience. It leads to prolonged mechanical ventilation, of course, because the longer we sedate them, the less SPTs we do. A prolonged ICU and hospital length of stay, increased costs, increased mortality, like I said, more PTSD. And there's quite a lot of work now to show that, especially with the benzos, which we'll talk a little bit more about later, this traditional feeling that we should protect patients from their ICU experience and we should protect them from their unpleasant memories of ICU is actually not accurate. And the more we sedate them and the more benzodiazepines in particular that we use, the more PTSD these patients go on to. So as with anything that we do in ICU, it's very important to quantify your level of sedation. So we do that with the Richmond Agitation Sedation Scale. Do you guys do a RASS score on your patients when you evaluate them daily?
No, so Nicole, it is in the protocol somewhere, but I think in reality no one does it.
Yeah, so we were very poor at this, like very, very, very poor. And actually, one of the regs is doing the MED on it, so it's now been incorporated into our nursing flow chart and into our where we write our doctor's orders on the flow charts. There's a little section there now for us to set a RASS target for the day and to say whether we are going to lighten sedation and attempt a SPT. So it's actually been great because it's forced us to think about it, where before I think we were being a little bit slack about this. So the RASS score can talk to a patient who's either very restless on the plus side of the scale where it goes up and or very drowsy heading to comatose deep sedation on the minus side of the scale. And generally where we want to aim for most of the patients in the ICU is to be a 0 to a -1, unless they have one of those absolute treatment indications that we said for deep sedation. This is another sedation scale. This is called the Ramsey sedation scale. This is used more in the theatre environment. It does come up in some of the ICU literature, but it's used kind of more for procedural sedation, things like colonoscopies and that sort of thing to quantify how deeply sedated the patient is for a procedure. So it's not really something that we use much in our practice. We stick to using the RASS score. So does the depth matter? I've gone on and on now about how we mustn't deeply sedate patients. So there's a group of investigators that do quite a lot of work on sedation in the ICU. They're called the SPICE study investigators, and they've got two big publications from 2012 and 2018 that showed that early deep sedation was an independent predictor of delayed time to extubation, increased risk of delirium, as well as an increased risk of death at 180 days. So those are quite convincing outcomes, and their recommendation is to aim for a RASS score of 0, as I said. But like we said, there are exceptions to that rule. We're not going to go through them again. So why do things change? If you talk to some of the old school intensivists, I don't know if any of you ever worked with Prof. Mitchell, but he will tell you how basically everyone in the unit was on lorazepam infusions when he started in the ICU, and actually until probably the early 2000s. Patients came in, they were basically given general anesthesia and benzo infusions and just left that way. So in 1998 was the first retrospective study that came out that showed that continuous infusions of sedatives led to a longer time on the ventilator and a longer ICU stay, and that was the first time that people sort of started thinking about it. And then in 1999 there was a follow-on randomized control trial that came from that said that there was a benefit from giving nurse-driven boluses of sedation rather than an infusion, so only giving boluses as the patients needed them. And then in 2000, the real landmark study came out, and that was the CREST study. So that was in the New England Journal of Medicine. And what CREST did was he randomized patients who received daily interruptions of their sedative infusions with setting a target level of sedation versus the standard of care. And the standard of care at that time was obviously just these ongoing sedative infusions. And it's quite weird to think, it's what we do now in our everyday practice. And only 24 years ago, it was this massive revolutionary thing that they stopped sedation and kind of saw what the patients were doing. So they showed that when you had a targeted sedation level and a daily, what we call a sedation vacation, or daily interruption in your sedation, you had a reduced time on mechanical ventilation, a reduction in your ICU length of stay, less PTSD, less requirements for, which is very important because it's less radiation exposure, but less CTs and MRIs, especially for the head injured patients, which I know you guys have a fair amount of there. It means that you can evaluate them quicker. Obviously, once they have monitors in, we do keep them sedated for a while, but it allows you to evaluate your patient's neurological status, of course, much easier. And they did note that there was a high incidence of all complications in the group of patients who received continuous infusions. And then following on from that came the ABC trial, or the Awakening and Breathing Controlled trial. And what this group did is they built on from Cress's work, and they said, okay, we're going to wake the patients up every day, but then let's do a spontaneous breathing trial once we've given them their sedation vacation. Obviously, if they were suitable for doing a spontaneous breathing trial. So they show that if you did the two together, which is what we advocate for, that you can extubate your patients up to 3 days earlier, which obviously in a high-pressured environment like we all work in, that's absolute gold to have 3 less ventilated days. The patients were discharged sooner from ICU as well as from the hospital and had a reduced mortality at 1 year. They did note that patients had an increase in self-extubation, which obviously self-extubation is not ideal, but the re-intubation rates were similar. So probably all that means is that they didn't get to the patients who were going to cope with extubation quick enough to take the tube out, and the patients ended up doing it themselves. But it's not to say that those patients didn't cope with being extubated. And then this group came and they said, okay, let's build on it a little bit more. So they came up with this nice bundle. And this is a bundle that we can use to kind of apply to all of our sedation, delirium, SBT, and sedation vacation practices in the unit. So the first point is to assess, prevent, and treat pain. You must do both the awakening and breathing trials in conjunction, like we said. Your choice of sedative should be light and avoid benzos, which we'll talk about. You should always do delirium monitoring, prevention, and management. Early mobilization and exercise is important, and a very, very important part of preventing delirium and of managing patients on lighter levels of sedation is family engagement and empowerment of the families and the patients together. So what do we do? Basically, the general principles are, if you don't need to sedate the patient, then don't. So if you see, I mean, it's always still, after so long of working in critical care, it always amazes me how tolerant patients will become of an ET tube, being ventilated, invasive lines, those sorts of things. There's many patients who cope just fine. And often the medical patients, the surgical patients with all of their pain, struggle a little bit more, but the medical patients are often quite tolerant of the interventions that we do to them. Very importantly is to target analgesia first. So the basis of our practice and of what is recommended in the PADI International Pain and Sedation Guidelines for ICU is to target analgesia first and to employ a method of analgo sedation, as we call it. We want to keep the patients as light as possible, use protocols and scoring systems, and like we said, do spontaneous breathing trials and early mobilization. So which drugs? It really depends on what you have access to, what you're comfortable with, what your patient profile is. But what we do strongly advocate for is, unless you have a really, really profound, compelling indication for it, to rather stay away from benzodiazepines, as they have loads and loads and loads of issues. During COVID, we used a lot of benzos because we had the patients ventilated and sedated for so long and so deeply, and weaning them off was really hard. And we had quite a lot of patients with quite bad adverse kind of neuropsychiatric PTSD, depression, lots of issues after there, which obviously is multifactorial, but if you can avoid the benzos, then you should. So the only times we use benzos is for alcohol withdrawal, for tetanus, and when we using it for tetanus, it's massive doses. So we'll only give IV for the first few days in the tetanus patients, and then we transition to nasogastric. Benzos to treat the spasms as well as to keep the autonomic dysfunction under control. And then we're talking like 20 milligrams hourly until the spasms are under control. Of course, you will use it in your management of seizures and status epilepticus. If you have patients who are habituated to benzos, you might give them a nocturnal dose of benzodiazepines. And very occasionally, in the non-intubated patient who's extremely anxious, we might give them a small dose for anxiolysis. So benzos increase your duration of mechanical ventilation when compared to all other sedation agents, including propofol and dexmedetomidine. It's very difficult to achieve your desired level of sedation with benzos. You end up having to give very, very high doses to get an adequate level of sedation. and then it wears off, and then the patient's very agitated again, and then you give another dose, and then the patient's very agitated again. And the other problem that we see fairly often is that patients can have paradoxical reactions to the benzodiazepine. So you end up giving what you think is an anxiolytic dose of benzos, and they end up having a massive paradoxical reaction and becoming even more agitated than they were to begin with. And there is an increased rate of delirium, as I said. So the bottom line basically is whenever benzos have been compared to propofol or dexmedetomidine, no study has ever found that benzos are superior, and so therefore we do not use them. So propofol, though we use it for everyone and around every corner, it's actually only licensed for 48 hours of sedation. So everything that we do longer than that is off-label. It's a GABAergic drug. The exact mechanisms of how propofol works is not well understood, but it does have some other pleiotropic effects like antioxidant and anti-inflammatory effects. The big concern that you will hear people talk about, or you might read about in the literature, is that for the development of the propofol infusion syndrome, it's really not something that we see in our adult practice really much at all. There have been a few cases of it at Red Cross, and more so it's more well described in the pediatric literature. So in Red Cross's ICU, they don't use any propofol sedation, particularly for the head injured patients. They don't. The head injured kids, they still use barbiturate infusions rather than propofol. So you should keep your dose to less than 4 milligrams per kilogram per hour in order to avoid the development of propofol infusion syndrome. The nice thing about propofol, of course, is that it's very titratable, quick onset, quick offset, very nice for doing our sedation vacation and rapid awakening trials, every morning. The registrar sees the patient at 6. They stop the propofol. By the time we come on the round at 8:30, we can decide whether the patient is awake enough and extubatable, and really accurately assess their neurological status. It does also shorten the time on the ventilator in various studies, but that depends on of course, what you are comparing it to. Obviously, just to remember that your propofol does cause a decrease in your systemic vascular resistance and your blood pressure and your cardiac output, and therefore quite difficult to use for sedation in those really hemodynamically unstable patients that you might get, especially the polytrauma patients, the post-theatre patients. Sometimes they just don't tolerate the propofol hemodynamically. So propofol infusion syndrome, just a little word on it quickly. Basically what happens is that propofol inhibits some of the key enzymes in your mitochondrial electron transport chain, and you get depletion of ATP production, and that happens in both your myocardium as well as in your skeletal muscle, and you get inhibition of sodium channels. So there have been a lot of studies that have done muscle biopsies in patients with PRIS, and they actually have massive muscle necrosis, so it's like a rhabdo kind of a picture. And clinically, they can have cardiac dysrhythmias. Usually it starts as a tachydysrhythmia, and then they kind of get a profound bradycardia thereafter. They might have very lipemic serum from all of the lipid in the propofol. They have a profound metabolic acidosis, obviously because of the mitochondrial toxicity. They can get renal failure. They might have a typical Brugada-like pattern on their ECG. As I said, rhabdo, which comes together with myoglobin and hyperkalemia. So opioids are the basis of what we use as sedation in our units, and good old morphine is really what we have the best access to and what we use the most often. And often we get away with just morphine and nothing else. So in 2010, there was a Swedish study by a guy called Strong. He looked at 140 critically ill patients. It was quite a heterogeneous group, some medical, some surgical. And he restrained them to no sedation versus sedation. There were no physical restraints used in the no sedation group. They had haloperidol for suspected delirium, and both groups got boluses of morphine. So in the no sedation group, they got boluses of morphine. And the sedation group was getting propofol for 48 hours and then transitioned onto midazolam, which obviously is not what we would do. And they were very deeply sedated. They used the Ramsey scale, but to a 3 or a 4, which is quite deep sedation. They did, however, have daily interruptions of their sedation until they were awake and extubatable. So Strom obviously found, you can look, that's the Kaplan-Meier chart that you can see there. The red line is sedation and the green line is no sedation. That's Kaplan-Meier of length of stay. And you can see there's a very obvious separation there with a much shorter length of stay in the no sedation patients. They were also, they had experienced more days without mechanical ventilation. And overall, they had 24 less days in the hospital, which again, it's a small study. So to put a lot of value on that is probably not correct, but I mean, it's a massive difference that they showed. There was more agitated delirium in the no sedation group, and they reported no difference in VAP rates, accidental extubations, or the need for any neuroimaging. So ketamine is something else that we use fairly often as an adjunct. It works really beautifully for patients who have the polytrauma patients, difficult to control analgesia, patients who are already at high risk for neuropathic pain. So our flail segment, multiple rib fracture patients, we use it fairly often. And although we don't look after burns that much, when we do, it would be something that we would employ as an adjunct in the burns patients as well. So it's an NMDA receptor antagonist, and the more we learn about ketamine, the more we're learning how amazing it is. And I mean, now it's even being used for the treatment of bipolar mood disorder, for refractory depression. So it really is an amazing drug. And like I said, very effective analgesic and sedative. Obviously, you just have to be careful of your dosing, because as we know, if we do increase to a higher infusion rate or higher dose per hour, the patients are at risk of having quite disconcerting hallucinations, and they can become quite dysphoric as well. So they often don't like the way they feel on the ketamine when it starts getting to a higher dose, even if they're not experiencing hallucinations at that point. The other great thing about ketamine is that it's cardiovascularly stable. And also that it's got very good bronchodilatory properties. So might be something to consider with your asthmatics, but obviously just be aware that it does increase your secretions. So just something to keep in the back of your mind. Dexmedetomidine, you guys probably, do you have dexmedetomidine? Have any access to Dex?
Sorry, Nicole, no, we don't. I mean,
yeah.
You have.
So it's pretty easily accessible in theatre for once-offs, like for awake fiber optic intubations. And if we are really struggling with a difficult to sedate patient or a really bad drug withdrawal, something like that, we can motivate to get it as an infusion in the ICU. But it's not something that we have kind of as an everyday standard, unfortunately.
Is it a cost problem?
Yeah, it's very expensive. I think a vial is like about 800 Rand, if I remember correctly, 850 Rand, somewhere around there. So for one vial, that's going to last you basically just over 24 hours, probably, if you run it at a standard rate for 70 kg person. So it's not something, especially at the moment with the austerity measures, we can't even afford to pay humans. So we're not buying expensive drugs at the moment. But how dexmedetomidine works is it's an alpha-2, it works on the alpha-2 receptors. It's an agonist at them. And that works both centrally and at the spinal cord level. So it works as an anxiolytic, as a sedative, as an analgesic, but it's also a sympatholytic. It doesn't cause much respiratory depression, so it's very nice in patients that you want to keep breathing spontaneously. So in your non-ventilated patients, it's really a nice option. And like I said, especially in our, in theatre, in our very bad airways that we need to keep breathing spontaneously to do an awake fiber optic, it's our sedation of choice. We don't, so the dosing recommendations in the package insert say to give a bolus and then to start an infusion. But because of the sympatholytic properties, you can get quite a profound bradycardia and hypotension if you give a big bolus. So we try and stay away in ICU from giving a bolus, and we'll just start an infusion and let it get to steady state very, very slowly. So this was a kind of a study that did a parallel trial looking at midazolam versus dexmedetomidine and propofol versus dexmedetomidine, and it ran over 3 years. And if you look at your time at targeted sedation without using any rescue medicine, if you use dexmedetomidine, compared to midazolam, you spend more time at your targeted sedation. With propofol, it was pretty similar. And in both the MIDEX and the PRODEX trials, if you look at the mechanical ventilation, you spent way less time being mechanically ventilated if you were getting dexmedetomidine compared to your usual drug. So what we do have a lot of is clonidine, and we use it pretty liberally. So clonidine is an oral alpha-2 agonist. There is an IV formulation. We don't have it at Critiscare. They do have it at Red Cross. And they call it the poor man's dexmedetomidine. It's not licensed for use in ICU, but there is currently a big trial going on in the UK to look at dexmedetomidine versus clonidine and whether they are equal or not. We use it a lot in our setting for patients with drug withdrawal, patients with alcohol withdrawal, those really agitated patients. It works very nicely. Can also drop your blood pressure. This you must get because this is used to control menopausal symptoms as well. Do you get clonidine?
So we do use it in ICU every now and then.
Yeah. So clonidine is great. We would normally start just with 75 mics as a test dose to see how the blood pressures respond, and then we'd escalate pretty quickly to usually 158 hourly. And in the really difficult to sedate, really difficult to control, very agitated patients, we might go to 300 mics 8 hourly, but obviously bearing in mind that you have to keep a close eye on your pressures there. And then, of course, if you stop clonidine abruptly, you can get quite big hypertension surges. So everyone, I always feel like sometimes we think we make more of a difference than we do. People try to make links where I don't know if there always are links, but there's quite a lot of work looking at whether the different drugs we use for sedation have any effect on disease states, and whether the choice of our sedative might impact on the immunological profile of the patients. So we know that it's mostly lab work, but we know that benzos are immunosuppressants, and they actually impair production of most cytokine lines by macrophages. Opioids also affect cytokine production, and that's mostly on a lymphocyte cell lineage. And propofol, like we said, may have antioxidant and anti-inflammatory effects. And there's a lot of work on this in sepsis and a lot of work in it in cancer as well, actually, looking at whether using propofol, TCIs rather than volatiles can have an effect on cancer recurrence, and whether avoiding excessive opioids in cancer patients can have an effect on cancer recurrence. Dexmedetomidine also has excellent anti-inflammatory effects, and it improves macrophage function, phagocytosis, bacterial clearance, and anti-apoptotic actions. But like I said, that is all in vitro work and not in vivo work, unfortunately. So basically, the summary of the sedation part of the talk is that the current recommendations include avoiding pharmacologically induced sedation at all if you possibly can. And if you absolutely have to, then primarily we would use analgesic sedation. And if you're going to go for sedation, then a non-benzodiazepine regimen such as propofol, maybe dexmedetomidine if you have it, and then adding ketamine as an adjunct. Using sedation scoring systems and targeting light planes of anesthesia, and doing our daily sedation vacation and spontaneous breathing trials. Okay, so the second part of this talk is a little bit quicker, just is about delirium. So we all know what delirium is. It's a fluctuating acute disturbance from your baseline mental state. It's characterized by an inability to direct, focus, sustain, and shift attention. And it's often coupled with a change in cognition, which comes in the form of memory deficit disorientation or perceptual disturbances. And that change in cognition should not be due to sedation or coma, and it should not be attributable to a neurological deficit which the patient is already known to have, such as being demented. So there's three subtypes of delirium. Hyperactive delirium is what we all know. It's that patient that's climbing out the bed and pulling out their chest drains and a danger to themselves and everyone around them. But what we often miss is hypoactive delirium. And because we miss it and we don't treat it, these patients tend to do worse. It's very often seen in elderly patients, usually more than being more than 65 is an independent risk factor. And these are those patients that are just really lethargic, they have decreased movement, they seem to have quite slowed mentation, they're not interacting with you as well as you would have expected them to. And unless you use a validated screening tool for diagnosing delirium, you're going to miss out on picking up on those patients with hyperactive delirium. And then there are some patients with a mixed phenotype, so they might have waxing and waning episodes of being more agitated and then more hyperactive. So we know that there are specific risk factors. We all always remember that what was dim top or whatever they taught us in medical school as the precipitating factors. But just remember that there are predisposing factors as well. And those predisposing factors, I always try and remember it as the patient with a vulnerable brain. So if you think of who might have a vulnerable brain, it's your elderly patients, lots of comorbid diseases, patients who are frail, and usually we say with a clinical frailty scale of more than 4, they are at increased risk. Patients who have alcohol and drug abuse issues, very high injury severity of illness scores, and anyone with baseline cognitive impairment. And what's very important to recognize is that we see delirium as an organ failure. So we call it brain failure in the unit. And it's very important, even when we're doing our SOFA scores and that sort of thing, we take it into account that if you are confused and delirious, then you have brain failure, it's an organ failure, and it needs to be taken quite seriously. So this is the CAM ICU diagnostic tool that you should actually be doing. So the recommendation by the group that came up with this tool, it's a guy called Wes Eli that did a lot of the work on this, is that you should actually be screening all of the patients that you can interact with. You should be screening every single day with a CAM ICU score. We're quite bad at doing it. We don't really do it that regularly, but we do. Obviously, if we are concerned that the patient is delirious, we will then apply the CAM ICU and go through it with the patient. So the first step is, do they have an acute change or fluctuating course of mental status? If they don't meet the first criteria, they don't have delirium, you stop there, you don't move on. If they meet that criteria, then you need to go on to the next one. So these are quite difficult to do in ICU patients in general, and especially in our environment where we see patients from all backgrounds with varying levels of education. It's some of the tests are quite difficult to employ in our patient subset. But basically, they need to show inattention, and there's a number of ways that you can do that. They can squeeze your hand when you say the letter A, or if they can't do it with letters, you can show them pictures. And if they make more than 2 errors, you go on to the next step. If they make less than 2 errors, they're not delirious. So step number 3 is using the Richmond Agitation Sedation Scale to assess their level of consciousness, and if their RASS is anything other than 0. So that's quite important because that does bring like I said, the hypoactive delirium into consideration as well. So they don't just have to be that on the plus side of that Bridgman agitation sedation scale. They can have a RASS score of -2 and then qualify as being delirious according to the diagnostic criteria. But if you find that the RASS is 0, which it can be because we know that these things do fluctuate, then you have to decide whether or not they have disorganized thinking. And Ivan's favorite question to ask is, does a stone float on water? And what's very interesting is to see how, as people's delirium gets better, they answer that question differently. So we had one guy during COVID, we asked him the one day, does a stone float on water? And he said, yes. And then a few days later, we said, does a stone float on water? And he said, well, maybe it depends. How porous is the stone? And so he was already starting to be able to reason a little bit better. And then a few days after that, we said, does a stone float on water? And it was an outright no. So it's quite a nice way that you can see as well as your patients' disorganized thinking gets better, that they start realizing that what the correct answer to that question is. So we make a big fuss about delirium because it's associated with the development of dementia and long-term cognitive impairment, with increased mortality, brain atrophy, again, all the things we don't like in ICU, increased time on mechanical ventilation, increased length of ICU and hospital stay, and increased costs of care. The little mnemonic that Wes Eli and his group proposed for the management of delirium is Dr. Dre. So the first part, the doctor, is disease remediation. So you have to remove the precipitants, such as sepsis, other hypoxemia, toxins, whatever it might be. Drug removal, so you stop any drugs that might be worsening the delirium. Our first port of call will always be benzos to stop them. Opioids and any other deliriogenic drugs. Don't forget that steroids can be a big problem there. And then your environment. So it's very important to promote sleep-wake architecture, which we know in the ICU is a massive problem. The lights are always on, everything is always beeping, everything is always talking loud, everyone is always talking loudly. So it's very difficult to promote good sleep-wake cycles in patients who are admitted to the ICU. And then as your patients start getting better, if it's elderly patients, if they've got hearing aids, give them their hearing aids. If they're extubated and they've got dentures, give them their dentures. If it's a patient that uses spectacles, give them their spectacles. Just allows them to interact with their environment in a more meaningful way, which helps to prevent and treat delirium. And then only after you've done all of that should you then kind of consider pharmacological treatment options. So the first thing that everyone jumps to is haloperidol, which is a butorphanone antipsychotic. It's anti-dopaminergic, anti-adrenergic. It's got some anticholinergic effects and maybe some anti-inflammatory effects as well. There's no role for haloperidol as prophylaxis. It's been shown in a number of studies that there's no benefit in delirium reduction, survival, or secondary outcomes. The problem is that this is the biggest study that it was done, and their incidence of delirium was quite, they said it was quite low. And maybe in centers where there's a very much higher incidence of delirium, it may be better. But 6 milligrams per day was the PKPD suggested dose. So basically, we don't recommend the use of haloperidol for either the prevention or treatment of delirium. It seems like I'm saying something weird, but actually the only reason that we use haloperidol in these patients is to control their agitation and to control their symptoms. It doesn't actually treat the underlying delirium at all. There is a move now towards using some of the atypical antipsychotics, and actually we've got quite a nice buy-in from our liaison psychiatry department, who will come and see the delirious patients for us, and we've started prescribing quite a lot of olanzapine, which we're finding very good results with, and it's working quite well. There is an ongoing RCT in the US looking at haloperidol versus ziprasidone, which is obviously also one of the atypical antipsychotics. So like I said, delirium is common. It's an independent risk factor for mortality, which people often don't realize, and it's associated with long-term cognitive dysfunction, which might be profoundly unacceptable to your patient population. Benzos and propofol are both implicated as a cause of delirium, but benzos more so. And dexmedetomidine, probably the least deliriogenic of what we have available to us. We should screen daily with the CAM ICU and consider our Dr. Dre, haloperidol not as a treatment option, only to control symptoms, and remember to implement your bundles of care. That is it. In time, yeah.
Well, thanks, Nicole. It's very enlightening. I think I've just got a few questions. I mean, have you?
Yes.
I can't remember. As far as I remember, people have tried melatonin just to try and reset that day-night rhythm in ICU.
So no, there's no evidence in RCTs that melatonin works to improve sleep in the ICU or as a better sedative than anything that we have available. So I think Jen has looked at it quite clearly, but there's no evidence to support it. Although there have been multiple trials, none of them have had positive findings.